Hello, welcome back. So, today we're talking about heart failure, and I want to get out of the way one of the biggest misconceptions of heart failure. Some people think when we say heart failure, it means that the heart has stopped working. And what we're going to learn is that's not what it means. So, heart failure is a syndrome where the heart cannot pump enough blood to meet the body's metabolic demands, or it can only do so when filling pressures become abnormally high. So, you want to think about it this way: the heart is still working, but it isn't working efficiently. And because of that, blood backs into organs. They might not receive the oxygen and nutrients that they need. So, heart failure isn't a single disease. It's the final pathway of actually many chronic cardiovascular conditions such as hypertension, coronary artery disease, and valve disorders. So we're often treating the consequences of this decreased cardiac output and congestion rather than fixing that actual underlying damage. So before we dive in, let's quickly go over what you'll be able to do by the end of lecture and class. So first, we're going to build a foundation by understanding what heart failure is and why it happens. And once you understand the underlying pathophysiology, those assessment findings and treatments are going to become much more logical. Next, we'll discuss the common causes, risk factors, clinical manifestations, and diagnostics used to identify heart failure. We'll also differentiate the major types of heart failure, including left versus right-sided heart failure and heart failure with reduced versus preserved ejection fraction. Because you're going to encounter these terms very frequently, both, on our exams, NCLEX, and clinical practice. And finally, we'll briefly introduce the nursing implications and lifestyle modifications that help prevent disease progression. And then during our in-class session, we'll build on this foundation by applying these concepts to patient cases, nursing interventions, medication management, and clinical decision making. So as you work through today's material, try not to memorize lists of symptoms. Instead, just continually ask yourself, why is this happening? And if you can explain the pathophysiology, you'll be able to reason through the assessment findings, diagnostics, and treatments much more effectively. So our agenda looks like today we're going to go over the pathophysiology. We're going to talk a little bit more about compensatory mechanisms, then go into causes, risk factors, continue with clinical manifestations, types of heart failure. We'll talk about reduced versus preserved ejection fraction and end on diagnostics. So heart failure is not a disease that develops overnight. Instead, it's the result of the heart gradually becoming unable to meet the body's demands. So the slide is going to walk through that progression. So step one, we have initial injury. So we always start with something that damages the heart. And the most common causes are going to be hypertension and coronary artery disease, but diabetes, valvular heart disease, cardiomyopathies, dysrhythmias, and even certain medications or toxins can also contribute. And over time, these conditions either weaken the heart muscle or make it work much harder than normal. So step two, we have decreased cardiac output. So as the heart becomes damaged, it can no longer pump blood efficiently. So remember that cardiac output equals heart rate multiplied by stroke volume. And in heart failure, the biggest issue is usually a decrease in stroke volume. So less blood is going to be ejected with each heartbeat. And as cardiac output falls, tissues throughout the body receive less oxygen and fewer nutrients. So patients may not notice this immediately because the compensatory mechanisms we're going to be talking about, but eventually they'll begin experiencing fatigue, weakness, exercise intolerance, and decreased organ perfusion. All right, so let's talk about step three, where we have those compensatory mechanisms. So now the body senses that cardiac output has decreased. So the body doesn't recognize heart failure. It's just simply thinking blood pressure or blood flow is inadequate. So to compensate, it's going to activate two major systems. We have the sympathetic nervous system, which is going to increase heart rate and contractility while causing vasoconstriction to help maintain that blood pressure. At the same time, the renin-angiotensin-aldosterone system, that RAS system, is activated by the kidneys. That causes sodium and water retention, which increases blood volume and preload. So initially, these responses are really helpful because they're going to temporarily maintain our circulation. But over time, they actually increase the workload on an already failing heart. So this is why we often say that the body's compensation eventually becomes part of the problem. Step 4, we have cardiac remodeling. So because the heart is working harder every day, its structure begins to change. The ventricles may enlarge and dilate, the muscles may thicken, and fibrosis develops. These structural changes are called cardiac remodeling. Unfortunately, remodeling makes the heart even less efficient, creating a cycle of worsening heart failure. Eventually, we get into step 5, which is decompensation. So the body's compensatory mechanisms are no longer enough. The heart cannot keep up with the body's demands, and this is when patients become symptomatic and often require hospitalization. So at this point, we begin seeing fluid congestion, worsening cardiac output, and evidence of poor tissue perfusion. So what happens because of all of this? So two major problems develop. The first is fluid overload or congestion. So if the left ventricle fails, blood backs into the lungs, leading to dyspnea, orthopnea, crackles, and pulmonary edema. If the right ventricle fails, blood backs into the systemic circulation, causing jugular venous distension, peripheral edema, hepatomegaly, and ascites. And the second major problem is poor perfusion. Since less blood is reaching the organs, patients then develop fatigue, confusion, cool extremities, decreased urine output, and exercise intolerance. One of the most important concepts to remember is that heart failure becomes self-perpetuating. Decreased cardiac output activates neurohormonal systems, and those systems cause vasoconstriction and fluid retention. That increases the workload on the heart, leading to more damage, which further decreases cardiac output. So without treatment, the cycle continues to worsen. So now that we've seen the progression of heart failure, let's talk about what the body does when cardiac output begins to fall. The important thing to remember is that the body doesn't know that the heart is failing. It only recognizes that vital organs aren't receiving enough blood. So again, it's going to try to compensate. And when cardiac output decreases, blood pressure begins to fall and organs receive less oxygen-rich blood. The brain and kidneys detect this decrease in perfusion and they activate several neurohormonal systems designed to keep us alive. So initially, these responses are pretty much life-saving. Our body is doing what it needs to do properly. But the problem, again, is that heart failure is usually a chronic condition. And what helps for a few hours or days might become really harmful over weeks, months, and years. So the first system activated is that sympathetic nervous system that I just talked about. That sympathetic nervous system, also known as our fight or flight response. Think about what happens when you're startled or you're running from danger. Your heart beats faster, it beats more forcefully, your blood vessels constrict to maintain blood pressure. The body is trying to increase cardiac output by increasing heart rate and contractility while also maintaining blood pressure through vasoconstriction. And initially, this works. The patient is able to maintain perfusion despite having a weaker heart. But again, there's a downside. A heart that's already struggling now has to beat faster and harder all day, every day. So imagine driving your car at full throttle everywhere you go. So it might get you to where you're going today, but eventually the engine is going to wear out. And that's exactly what happens to the myocardium. The second major system is that renin-angiotensin-aldosterone system, or the RAS. So this starts in the kidneys. So when the kidneys receive less blood flow, they interpret that as dehydration or low blood volume, even though the patient may actually have, in fact, too much fluid in this case. So to compensate, the kidneys release renin, which ultimately produces angiotensin II and aldosterone. Angiotensin II causes vasoconstriction, increasing systemic vascular resistance and blood pressure. Aldosterone tells the kidneys to retain sodium and water. So the body hopes that by increasing blood volume, there will be more blood available for the heart to pump. Again, this sounds really helpful at first, but in heart failure, the weakened heart can't effectively pump this extra fluid. So instead, the additional volume increases preload and causes congestion and edema. So let's put these things together. The sympathetic nervous system says, pump harder and faster. And the RAS system says, hold on to more fluid. So both systems, they're trying to improve circulation, but the failing heart can't keep up, and instead they'll increase the heart's workload and make the problem worse. This is why understanding those compensatory mechanisms is really important, because almost every medication that we're going to use for heart failure is designed to interrupt one of these pathways. Beta blockers, if you don't remember from PHARM, beta blockers reduce sympathetic stimulation, which allows the heart to slow down, decrease oxygen demand. Our ACE inhibitors, ARBs, block the RAS pathway, reducing vasoconstriction and limit harmful remodeling. We have mineralocorticoid receptor antagonists like spironolactone, which block aldosterone and help reduce sodium and water retention while also decreasing fibrosis and remodeling. And we have those SGLT2 inhibitors, although they're originally developed for diabetes, have become more foundational in the therapy of heart failure because they promote sodium and glucose excretion and reduce preload and afterload and provide additional cardiovascular and renal protection. Diuretics, really helpful, are going to remove excess fluid, relieve those symptoms of congestion, and although they don't stop the disease process itself, understanding these compensatory mechanisms are going to help explain why these medications are going to improve outcomes. So now that we understand how heart failure develops, let's take a little closer look at what causes the initial damage to the heart. While there are many risk factors, a few really account for the majority of heart failure cases you'll see in practice. So the number one cause of heart failure is hypertension. So think about what happens when someone has uncontrolled high blood pressure for years. The left ventricle has to pump against increased resistance every time it contracts. And this increased workload causes the heart muscle to thicken, a process called left ventricular hypertrophy. And at first, the thicker muscle helps generate more force, but over time it's going to become stiff, it doesn't relax well, and it eventually weakens. The second major cause is coronary artery disease, and we know as plaque builds up in the coronary arteries, less oxygen reaches that myocardium, and when the heart muscle doesn't receive enough oxygen over time, it can't contract as effectively. So patients may initially develop ischemia, but persistent coronary artery disease increases that risk of myocardial infarction and eventually heart failure. Previous myocardial infarctions, so a previous MI is one of the most common causes of heart failure with reduced ejection fraction. And we'll talk about that coming up. But when part of the myocardium dies, that muscle is replaced with scar tissue. And scar tissue can't contract, so the remaining healthy muscle has to work harder to maintain cardiac output. And as more muscle is lost, the ventricle dilates, remodeling occurs, and systolic function declines. And diabetes. Diabetes contributes in several ways. So patients with diabetes have a much higher risk of developing coronary artery disease and hypertension. Diabetes can also directly damage the myocardium through chronic inflammation and microvascular disease. And because diabetes often exists alongside hypertension and obesity, these conditions work together to increase the risk of heart failure. The remaining conditions either increase the workload of the heart or directly damage the myocardium. But I wanted to go over the top 4.